or baby boomers, and that is a big focus of Hep C prevention and HCC prevention. So other reasons, what's the impact of hepatitis C? So Hep C mortality exceeds the mortality related to HIV. And that occurred back in about 2007. As you can see, these graphs have changed, and there's basically increased burden due to hepatitis C, and the treatments that we have for HIV has really kind of led to a decline in mortality due to HIV. So in 1999 to 2007, HCV-associated mortality increased by 50%. And in 2013, 19,368 HCV-related deaths occurred. 73% of those deaths occurred in people that were between 45 to 64 years old, and the median age of death was 57. So if you think about that, you know, most people nowadays are living to be, 67, 70, or I'm sorry, 77 or so. And so this represents almost a 20-year loss in life expectancy. And that's why this is important, because people are dying at a younger age because of this disease. So what happens to you if you have hepatitis C? So here on the left, I show you a normal liver. And over time, with hepatitis C infection, and most people, again, don't feel anything, they're asymptomatic, they start having fibrosis. And they go from stage 1 to 2 to 3, and then stage 4 is cirrhosis, where they have nodular livers and stuff. And once you develop cirrhosis, then there's increased risk of developing liver cancer. And unfortunately, there is no good treatments for liver cancer. Liver cancer is actually one of the fastest growing cancers in the U.S. It's the 5th leading cancer in the U.S. And like in our state in Texas, it is the fastest growing cancer. So this is an important area, and the majority of these cancers are coming from hepatitis C. So there are many ways you can get liver cancer, but chronic hep C increases the risk. And now, if you detect the cancer early, then you could potentially resect it. But unfortunately, people, if they come in because they have symptoms of the cancer, their prognosis is very poor. So let's talk about, well, the first thing to prevent the cancer from even happening is to just prevent hepatitis C, because that's a big component. So how is Hep C spread? So the majority of Hep C spread is occurring through injection drug use. But we do see sexual transmission of hepatitis C, but this is in a subset of the population. We don't see Hep C transmission in heterosexual male to female, but we do see it in men who have sex with men. And usually this is related to more aggressive practices where there is trauma or blood. Because remember, hepatitis C is a blood-borne disease. And we see it in transfusion, especially before 1992, which is when we started screening our blood supply. And then there are other reasons. So who should be screened? Well, there's the high-risk groups. This is what our screening guidelines had used to be, which is, anyone with abnormal liver function tests, injection drug users, those who've been in jail, long-term dialysis, anyone who's had tattoos or born to someone with Hep C, or any healthcare provider that has been exposed, and then also anyone with HIV, and then also anyone born in a high-risk country. So this is considered risk-based screening. But risk-based screening is not enough. It is estimated that 75% of the people who have hepatitis C don't even know that they have it. And as I will talk to you later about, there are new treatments that are curative, and so there has been a change as of 2012 in terms of who should get screened. You should continue to do the risk-based screening. You know, anyone with abnormal liver function tests should be screened for hepatitis B and C. But the U.S. Preventive Service Task Force recommends that you should also do a one-time screening of baby boomers. So anyone born between 1945 to 1965. So remember, when I was talking to you about the high rates of Hep C infection that were occurring in the 1980s, it's that cohort that has a high prevalence of Hep C, estimated to be between 4 to 5%. And so this is an important group of people to test, because they may be completely asymptomatic, they may have completely normal liver enzymes, but they have hepatitis C, and they may have untreated or undiagnosed cirrhosis. So the initial way to screen is to do antibodies against hepatitis C, and then to confirm the diagnosis, you have to do a PCR, HCV RNA. So let's talk about diagnosis. I'm just, as an overview, preparing for Hep C treatment, we first have to screen, so we have to do an antibody test, and then we have to confirm that they're actually antibody positive, so we do an RNA, and then we have to find out what type of genotype they have, although that may become less important as we are moving into an era of these drugs that are effective for all the different genotypes. We should also figure out how much scarring is in the liver, and I'll talk to you guys about that. And then you know, what do you treat with? So the first step, Hep C, is to first do an antibody. So you first do an antibody, and if it's negative or non-reactive, then you're done. You don't need to do anything else. If the antibody is positive, reactive, now you can't stop there. That does not mean that they have hepatitis C. You actually have to follow this up with an HCV RNA test. Now, there are labs that do a reflex test, so they'll do the antibody, and if the antibody is positive, they'll automatically do the RNA. If you don't have access to that, then you do have to bring the patient back and do an RNA test. And so if the RNA is negative, and as you screen more of the baby boomers, because the prevalence rate, you know, is like 4 or 5%, you're going to have more people with undetectable viral loads. So that may be a false HCV antibody, or it could be that they had hepatitis C and cleared the virus. Regardless, if their HCV RNA is not detected, they do not have hepatitis C, and they do not need any kind of treatment. If you're testing them because they are, you know, injection drug users or something, then it would be appropriate to retest if they have ongoing risk. But otherwise, if they're like baby boomers, they're not using any drugs, or they're not, you know, exposed to hepatitis C. If you've tested them once and they're not detected RNA, you're done. Now, if their RNA is positive, which you probably will see in about 60 to 70% of the patients that you do an RNA test, if it's positive, then they do have hepatitis C infection, and they do need to then get treated. So the next step that we have generally done, and again, this may be a changing paradigm, is we have gotten a Hep C genotype. The genotype is there are 6 different types of Hep C genotypes. The most common one, and which we see the most of, is genotype 1A. It's about 60%, and 1B is about 19–20%. And then you see less than 10% of like 2s and 3s. This is just from our hospital at Parkland. So the vast majority of the people that you will see will be genotype 1. And the treatments that we have are geared towards that genotype. All right, let's talk a little bit about fibrosis. So there are 4 stages of liver fibrosis. F1, so F0 would be basically a normal liver. So if there is some scarring, some of this blue stuff around the portal triad, then they're considered to have F1. So there is some scarring, there's some damage to their liver. As the fibrosis increases, it goes to F2, which means that they have some moderate amount of fibrosis. F3 is this is where they have bridging fibrosis, and they are considered to be kind of pre-cirrhosis. We would consider it moderate fibrosis, and F4 is when they have cirrhosis, and that's at that point is when we would start screening them for liver cancer. So now, how do you screen for fibrosis? Well, and I don't know if any of you all are trying to treat hepatitis C in your primary care clinics, but obviously you're not a hepatologist, and therefore you're not going to be doing a liver biopsy. And I'm actually an infectious disease physician, but I don't do liver biopsies either. And in our Hep C clinic, we don't do liver biopsies unless the insurance company requires it. So we are really moving into non-invasive ways to stage liver fibrosis. So there are many different things, and they're not all, I mean, again, there are surrogates for the biopsy, so you have to take them with a little, caveat, but so there's a FIB4 score or APRI, which is basically using the ALT, AST, platelets, age, and putting it into a calculator, and then you get a predictive value. What's the likelihood of this patient having advanced liver disease versus not? So that can be useful. It's kind of a little, you can just do it from, routine labs. Then there are a little bit more sophisticated measurements, like FibroSure, or what we have here at Parkland's called a fibro test. And so this is a send out. You'd have to, draw blood and send it to a thing. But what you get back is something that will give you an F score. So it'll say F0, F1, F2, F3, F4. And often insurance companies would like to see that to make sure that the patient, it's appropriate to be treating this patient. It's also useful to do imaging like ultrasounds, again, especially to look for cirrhosis or liver cancer. Now, I will say that sometimes the ultrasounds don't always reflect how much, like sometimes the radiologist may overcall and call it a nodular liver and say the patient may have cirrhosis when that might not be true. So you have to be a little bit careful with that, but it's useful to have. There are other types of ultrasounds called elastography. Again, more specialized centers will have it. We have that here at Parkland, but it is not FDA approved, and the Texas Medicaid program will not take that report. There is an FDA-approved machine called the FibroScan, which is a vibration-controlled transient elastography. Again, but this is an expensive scan, and so only specialized centers have it. But this is something that most insurance companies will take because it has been validated against liver biopsies. And then even more sophisticated is the MRI elastography, which again is not very widely available. So there's a lot of different ways that are non-invasive to try to stage liver fibrosis. But I'm going to walk you through the FIB4 because I think this is a relative, an easy way at the bedside to be able to got to get a gestalt of what's going on with the patient. So the FIB-4 score uses the age, because especially with hepatitis C, age has a huge impact on development of cirrhosis. So the longer you've had hepatitis C, the more likely you are to have cirrhosis. And so the older you are, the more likely it might be. The platelet count. Most people that have advanced liver disease or cirrhosis will have lower platelets, less than 150,000. AST and then ALT. So then you just plug in the numbers here, and then you get a number that comes up here. And so if the number is less than 1.45, then there is a negative predictive value of 90% for advanced fibrosis. If this number is greater than 3.25, then there's a 97 specificity and positive predictive value of 65% for advanced fibrosis. It can be useful. Now the problem is when it's kind of in between, when it's between 1.45 and 3.25, and we see that quite often. And then it's really kind of a little bit harder to interpret. But again, this is just one modality. You can use different modalities to help you. Other screening things, if you determine that your patient has cirrhosis based on, the FIB-4 score, and what I do is I kind of look at all of these things. Like often when I see the patient, they may not have a fibro test, but they often have the ultrasound. So I look at the ultrasound, I calculate the FIB-4, and I kind of get a gestalt of what I think might be going on. Then I get the fibro test to help confirm, try to confirm that. So anyway, let's move on to, so say that you've now decided that this patient probably has cirrhosis. Then what you want to do is you want to do HCC screening or surveillance. And you have to do this every 6 months. The reason to use the ultrasound as a screening modality is that it's cheaper than trying to do CT or MRI, safe, and there's reliable data. It is a little bit operator dependent, and maybe also a little bit difficult in obese patients. But if you do see something that's abnormal, then it will require getting a CT or MRI. But screening for HCC by ultrasound in patients with cirrhosis has improved survival. So if patients screened, they were more likely to survive than those who did not screen. So that's important. All right, let's move on and talk a little bit about education. Patients, what do you talk to the patients about? So what should you counsel them about if you diagnose them with hepatitis C? First of all, it's important to explain to them how Hep C affects their liver. I usually will tell them, the progression to cirrhosis and then the complications you can get from cirrhosis. Simple things also that people don't talk to them about because they're so focused on the progression to cirrhosis or the treatment and stuff. It's just the simple, how do you avoid spreading it to others? So we, tell them, look, you can't spread hepatitis C from kissing or hugging or sharing utensils. And you'll be surprised at how many people are, you just see this relief that comes over their face because they're like, oh, I just wanted to make sure I could play with my grandkids. And so it's, it's important to have that discussion. But, I always tell them not to share a toothbrush or a razor just because if you get a nick and blood gets on it and somebody else uses it, then there's a potential for transmission, although probably very rare. If you do have a cut, then it's important to cover it. And then other strategies to reduce damage to the liver, and that would be to, avoid alcohol. So especially in people with hepatitis C, if they are a heavy drinker, their progression to cirrhosis is much faster than if they're a light drinker. And so that's it. To me, it's like adding fuel to the fire. And so it's really important to talk to them about reducing that risk of progression to cirrhosis by avoiding alcohol. The other thing, which, again, hasn't been proven, but obesity also can cause fatty liver and progression of liver disease. And so I also talk to them about exercising and trying to maintain a healthy lifestyle. But the most effective way to improve liver disease is to get rid of the virus. And so we can prevent HCC from developing if we can cure hepatitis C. So, unlike some viruses like HIV, where we put people on treatment in order to suppress the virus, and that treatment does improve life expectancy. We saw that in the earlier slides when fewer people are dying from HIV, but it does not cure the infection. Hepatitis C is actually one of the few viruses that after treatment we can actually cure. And so people, you don't have to take lifelong treatment. And so the goal of treating hepatitis C is actually to obtain a cure. So we have new medications that can be used to treat hepatitis C. The effectiveness of these medications is amazing. So we are, what I would say, in the era of directly acting antivirals. We no longer use interferon. All the medications we give are oral. And for the most part, they can be given for like 3 months. And they all have cure rates of greater than 90%. So 9 out of 10 people that you treat, you will be able to cure. Now, there are a lot of different hepatitis C medications available, and I just listed some of these here. And I don't have the time to go through all of these medications. I'll go over it a little briefly. Sulfoxaflor lidipasvir is Harvoni. This is probably the one, at least my patients come, oh, that's that pill they talk about on TV. It's 1 pill once a day. It's a 12-week regimen, but it is not, you can't use it in all the genotypes. You can use it in genotype 1, which is the most common one, 4, 5, and 6, but you cannot use it in genotype 2s and 3s. Vicarapac is actually probably going to be phased out, at least in Texas Medicaid. It used to be the preferred agent, and that has just changed as of Monday. And so I'm not going to talk about that much because I just think that that's not going to be used as much. Declinza and Sovaldi also probably not going to be used as much because you have to get this from 2 different companies. It's 2 pills, but it is pan-genotypic, although only FDA approved for genotype 1 and 3. This is something that I sometimes will turn to in my HIV patients because I have a little bit more flexibility with Declinza because of drug interactions. Zapatir is another drug that is FDA approved for patients with renal disease. So one of the Achilles heel for Harvoni is that you can't use it in patients with creatinine clearance less than 30. And Zapatir can be used in that population. It can be used in dialysis patients. And then we're going to go through some of the new ones. I'm not going to talk about Vosefi, which just came out, because this is really for people who have failed a DAA. And I suspect the majority of people, if you treat them, will probably have never been on a DAA. So it's probably not worth going over that. So let's talk about some of the new drugs that just came out in the last year or so. Can you guys still see me or hear me? Okay. I think I clicked something. Sofosbuvir, velpatasvir, or Epclusa, is a nucleoside NS5B inhibitor, and it's pan-genotypic. So what does that mean, pan-genotypic? It means that it covers every single genotype. I told you that there were 6 different genotypes it works for all of them. So it's easy to remember. It's 1 pill once a day for 12 weeks. That's it. It doesn't matter the genotype. You just give the same thing, everyone. In fact, we are trying to try to get rid of even doing a genotype by just, because it doesn't matter what the genotype is, we're just going to give it for 12 weeks. And you give it with or without cirrhosis, you just give 12 weeks. Now, the only group that you change anything with is if they have decompensated cirrhosis, then you add ribavirin. And that, again, most likely if you had a patient that was decompensated, meaning that they have ascites and encephalopathy or anything like that, you would really probably need to refer them to a specialized center. And now sofosbuvir or Epclusa you cannot use this with patients with renal disease. So if their creatinine clearance is less than 30 or they're on dialysis and stuff, you cannot use Epclusa. But this is the efficacy. It works really well. It was compared to sofosbuvir and ribavirin, which was what we had to use before. And compared to that, this Epclusa is much more efficacious. They also compared it to sofosbuvir and ribavirin for 12 weeks, which is what we used to use for genotype 2. And again, Epclusa is also more effective. So that's kind of the drug that we go to for genotype 2s and 3s. In patients, in terms of drug interactions, so you do have to be careful in these patients if they're on amiodarone. And this is for any of the DAAs, especially if they're sofosbuvir based, because of the symptomatic bradycardia. You also need to be careful if they're on, or you can't use it if they're on rifampin. St. John's wort, I think I'm seeing less and less people using that now, but people used to use that because they thought it normalized liver function tests and they thought it would improve their hepatitis C. So it's something to ask. It's an over-counter thing, but you don't want them to be taking that. You don't want them to be taking Tegretol. The other big thing is antacids or H2 blockers and PPIs. So you can do an H2 blocker, but you have to separate out by 12 hours. You cannot use a PPI. So, or at least prescription strength PPI. So, a lot of times patients are willing to stop the PPI. I mean, again, this is only 12 weeks, and if they can just stop it for 12 weeks, then it would be useful. But the thing is that the drug needs an acid environment to be absorbed appropriately. And so if you decrease the acid by the PPI, then the efficacy of the drug actually decreases. HIV medications that you can't use is efavirenz and tipranavir. In terms of side effects, not a lot of side effects. I mean, we do see headaches with this, fatigue, some nausea, but not too bad. And if you have to use it with ribavirin, then you might see more of that, but that's mostly because the ribavirin causes anemia and fatigue. The next drug that I want to talk about is glasapavir or pibrentasvir, also known as Mavorix. At least in Texas, it just became the preferred agent for Texas Medicaid. So this is an NS3/4A inhibitor and an NS5A inhibitor combined into a pill, and it is effective against all genotypes, genotype 1, 2, 3, 4, and 5, and 6. Now, it is not one pill once a day like Epclusa. It is 3 pills once a day. So it's in a little pack like this. They have to take 3 pills. It works for for all genotypes. And if you're treatment naive or experienced, and when I say experienced, it means that if you've had pegylated interferon, so the old Hep C treatments, not the new ones. And if you don't have cirrhosis, you can actually use this for 8 weeks. So it's even shorter. But if you do have cirrhosis, then you need to do 12 weeks. So that's why, staging liver disease is important, because it makes a difference between whether you give 8 weeks or 12 weeks. Now, there is a little bit of a caveat in patients who have had pegylated interferon, ribavirin, and they're genotype 3, then you actually want to treat them for a little bit longer, for 16 weeks. This is just going over treatment experienced patients, and I'm not going to go into this that much because it's probably not the population that you would be seeing. So in terms of side effects, headaches in 9 to 17%, nausea in 6 to 14%, diarrhea in less than 10%, and I have nausea on there twice, sorry. Okay, so in terms of drug interactions, you can't use this with anticonvulsants, with the rifamycins, with estrogen. It causes an ALT elevation, so you do have to be careful about this in your women. St. John's warts, like the other drugs. Now, statins are a little bit also problematic. So if they're on atorvastatin, lovastatin, or simvastatin, you don't want to give Mavorite. Now, a lot of times our patients are on this, and it'd probably be fine if they stopped it for 8 weeks or 12 weeks, or you can switch them to something like pravastatin. So that's what's kind of recommended. In terms of HIV medications, atazanavir, darunavir, lopinavir, ritonavir, and efavirenz, you can't use with that because this is all liver metabolized. So any of the drugs that are metabolized through the liver can potentially interact with it. And that's why the statins can be a problem, and the HIV medications. But because it's liver metabolized, you can use this drug in patients with kidney problems, with on dialysis. This will work perfectly fine. So the efficacy, this is has very high efficacy, and it works against all genotypes. So that is kind of hepatitis C in a quick or brief overview of hepatitis C, from prevalence and impact to diagnosis and treatment. And I'm here to answer any questions that you might have.
Thank you, Dr. Jane, for this wonderful presentation. We're going to move on. Well, before we move on, I would like to thank AIDS Education and Training Center Program, South Central, for collaborating with us in this particular webinar. Thank you so much. And if you would like to ask a question to Dr. Jane, please either write your question, or if you are dialed in through your telephone, I would like to ask the presenter a question, use the raise hand icon, and your line will be unmuted. There is one question, Dr. Jane. It says,
yeah.
What conditions existed in the 1960s and 70s that increased persons being infected with Hep C?
So the thing is that we did not know about hepatitis C back in the 60s, 70s, and stuff. We did see people coming in with abnormal liver function tests. We tested them for hepatitis A. We tested them for hepatitis B. They didn't have that. We used to call them non-A, non-B. We just didn't know what it was. And because we didn't know what it was, we didn't know how it was transmitted. And so people, were donating blood, they were sharing needles, things like that, and hepatitis C was getting transmitted. It wasn't until probably the late 1980s, or late 1980s, that hepatitis C virus was found. And then it wasn't until 1992 that we actually implemented screening the blood supply. So yes, we did have a period in the 16, 70s, and 80s where we had a virus that we did not know what it was, and we definitely didn't know how it was being transmitted. And so that's probably the reason why there were so many infections occurring at that time.
Thank you, Dr. Jane. And I am going to answer this question. We are getting some questions on how participants can get a copy of the slides. The slides will be sent to you via email after the webinar is over, and you can also visit our website www.nchph.org, and you will get a copy of the slides as well as the recording for this webinar. Now, there is another question, Dr. Jane, and it says, how often do you need to test high-risk patients?
So that's a good question. In the HIV world, it is recommended that if patients have ongoing risk, that you test them yearly for hepatitis C. You know, for example, if you had someone that was using injection drugs and you knew they were using it or they intermittently used it, then I think I would test them yearly, and especially if you notice their liver function test becoming abnormal. And it's also recommended in men who have sex with men, especially if they have multiple partners. But like if you had someone that came in, for example, it's recommended that anyone that's foreign born, I don't necessarily think you need to test them yearly or anything like that. I mean, their risk factors probably, they might have gotten exposed to hepatitis C from even medical, like vaccinations or something, especially in foreign countries. And so it's important to test them, but then I don't think you need to retest it. Similar to a liver function test. I mean, once you test it, unless it, it goes down and then like several years later it comes back up, then probably retest it again at that time.
Great, thank you so much. There is another question. After the course of treatment, is follow-up testing and or observation recommended? If yes, how long after?
Yeah, sorry about that. That is actually a very important question, and I should have mentioned that when I was talking about treatment. So the course of therapy I talked about was 12 weeks for the most part. We have that MAVRA, that's 8 weeks. But once they finish treatment, you can't say that they're cured. You have to wait 12 weeks after they finish treatment, and then you need to check a Hep C viral load. And if that Hep C viral load is undetectable, then they're considered cured. Now, should you test them after the 12 weeks? That's a little bit more controversial. We used to, when we used to give pegylated interferon, we used to wait 24 weeks before we tested them. So I will generally test them again, like, a little bit later, like maybe 6 months to a year later, just to make sure that, there wasn't a late relapse or anything. But I think the data is pretty strong that it's been 12 weeks since they stopped treatment and the viral load is undetectable, that you can say that they're cured. Now, if they continue to engage in high-risk behavior, they can get reinfected again. There's been studies in injection drug users that have been treated, and they see rates of maybe 2% or so. And so that's why it's important to kind of continue to monitor people that get treated, especially if they have ongoing risk.
Great, thank you so much. There is another question. What are the options for anticonvulsants on MAVRA? Do all have to be discontinued?
So one thing, we've used this with our HIV medicines, is Keppra. Keppra is one of those drugs that doesn't seem to interact with, it's not metabolized to the liver, I believe. And so we can use Keppra, for example, in our HIV protease inhibitors that are metabolized to the liver. So I suspect Keppra might be an anticonvulsant that I put a broad category of anticonvulsants, but you'd have to really look at the specific drug and check the interaction.
Thank you. The next question. Are rapid Hep C tests available?
Yes. So there is the OraSure. hepatitis C test, which is just a finger stick. It can be done. It's point of care basically. And we're planning to use this actually in health fairs and stuff. And so you basically have a kit and you put the blood on it, and then it takes about 20 minutes and you can get a result of a positive, negative. Now, that only gives you the antibody result. So you still have to follow that up with an RNA testing if it's positive and draw blood to do the RNA. But it is a quick point of care test that could be done like in the clinic if you didn't want to draw blood. And actually, it might be a nice thing. The only thing is, it is much more expensive than the antibody. The antibody test, I mean, there are reduced price antibody tests that, $8, $10 or something. This one is like $15 to $20. So it is a little bit more expensive. But the nice thing about the point of care testing is that if it's positive, then the patient's right there and you can draw the RNA testing. Whereas with the blood test, unless you do the reflex, the problem with the blood test is that when you get the antibody result back, you have to bring the patient back to get the RNA testing. So it's a two-step process. And that's where we sometimes lose people in the cascade.
Thank you. This is a follow-up questions on the rapid test. How sensitive is the rapid test?
My understanding it is fairly sensitive for detection of hepatitis C.
Thank you.
And it's FDA approved. Yeah.
Sorry.
Yeah.
Go ahead.
It is FDA approved, and like for example, our health department is we have a student organization here that does Hep B and C testing in the community, and they're providing the point of care Hep C testing for them to do so.
Thank you, Dr. Jane. Have there been any cases showing drug resistance?
Drug resistance. So yes, but only after treatment. You mean like before they even get started on treatment?
Yes, that's the question.
Yeah. So far I have not heard of that. Thankfully, the good thing about the drugs that we're using is we're using combination therapy, so that reduces the risk of any one mutation causing the drug not to work. But so far we have not seen that. Part of it may be because the hepatitis C virus is different from the HIV virus, for example, which we have seen transmission of drug-resistant HIV virus, particularly the K103 mutation that was associated with AAA use. With the hepatitis C virus, it's a cytoplasmic virus, and so once the virus, once you're on treatment and the virus is gone, then it's cleared from the cytoplasm, and so that you don't have ongoing transmission. But again, it's possible we might see that, but so far I have not heard that. I want to backtrack just a little bit, though. There are mutations that we, for example, Zapatir, one of the drugs that we use, people can have some baseline RABs, they call them resistance-associated mutations. They don't have them because they've been exposed to the drug. They're just baseline. They're just there in the population. And so, like for Zapatir, it was found that those patients that had this mutation wasn't as responsive to Zapatir. And so with Zapatir specifically, if you're a genotype 1A, the FDA actually recommends that you get this NS5A testing. And then if it's negative, then you can just treat for 12 weeks. But if it's positive, then you actually have to add ribavirin and treat for 16 weeks. So that may be a little roundabout way of explaining that question or trying to answer that question.
Thank you, Dr. Jane. And there is a question that I believe many of the participants are interested in. The question is this treatment available to an uninsured FQHC patient? Can the
Yes.
Can the 340B drug program accommodate these treatments in the primary care setting?
Okay. Let me tell you what we have done. So I work in Parkland Hospital, which is a safety net healthcare system in Dallas, Texas. Many of our patients are uninsured. I also work, in the HIV clinic where we have a lot of Ryan White patients and stuff. So if they are uninsured, what we do is we petition the drug companies to get free medications. And we've actually been doing this with FQHCs in South Texas, and we're training primary care providers in South Texas who are seeing uninsured patients, and we're teaching them how to get these drugs for them. So the cost would be the cost of the labs, but there's no cost to the medication. So all of the pharmaceutical companies, Gilead actually has a very good program, and they are the makers of Harvoni and Epclusa. And so you can go to their website. There's a form called the Patient Assistance. It's the Patient Assistance Program. And so you and the patient will have to fill out the form. It does ask the patient to, give their proof of income. So they have to show that they're not insurable. And then you fill in their information about, their hepatitis C virus and genotype and all this stuff, and then the drug that you want and the duration. It gets mailed or faxed to the company, and then they contact the patient and they approve them usually within a few weeks, and the drug goes directly to the patient. In our program, we ask the patient to call us. We bring them in, we do a little education. Our pharmacist does an education to how to take the medication, side effects and stuff. We start them on treatment, and then we follow them. We were seeing these patients once a month, and we're finding that we don't even need to do that. We can just do a lab test to make sure that the virus is going down, and we do a check-in through a virtual visit, just to make sure they're, getting their refills, not having side effects. And then they finish treatment. We get another blood test, make sure that they're, really undetectable. And then we get the most important blood test, which is 12 weeks after they finish, the SVR12. And if they're negative, then we bring them in after that. We, say, hug them, say, hey, yay, you're cured. If they do have cirrhosis, then we do have to explain to them that, you've got to get more evaluations done. You still have cirrhosis, and you've got to continue, getting surveillance done.
Excellent. Thank you, Dr. Jane. And this is not a question. I believe this is just a follow-up on the quick test. We have some information from Adam Gilbert saying that some state-funded programs can provide the OraSure testing supplies to FQHCs. So,
okay.
So I believe this is excellent information for those looking for additional resources. And I don't see any additional questions in the queue. So I would like to thank one more time Dr. Jane for her time and support. We need people like Dr. Jane to keep us abreast on topics such as the Hep C infection update that we just received. For all of you who are not familiar with the National Center for Health and Public Housing, visit our website, nchph.org. You can find recorded webinars, monographs, training manuals, newsletters, information on our annual conference, and information on one-on-one training. Join our mailing list, and you will receive HRSA updates, Medicare updates, funding opportunity announcements, information on senior programs, and other resources and services. You can also follow us on social media, Twitter, YouTube, and if you have any additional questions, this is the contact information for all of our members. So thank you one more time. to all attendees, and please do not forget to complete the post webinar survey. Thank you and have a great afternoon.